Welcome back to St. John's webinar series for health education. Today's topic is Sleep Better, Live Better. I am Denise Mananas. I'm the Senior Director of External Affairs for St. John's. And before we begin, I'd like to acknowledge our team here at St. John's who put these programs together. From our IT department, Mike Matalal and Jason Latour, who are our producers. And Nancy Anabi, our community liaison, who has done all of the legwork to get the speakers and all the work done to make this happen. And Olivia Hunter, my assistant director of marketing, who is our media production specialist, and she's just invaluable and wonderful. So today, and I'd like to also acknowledge our community partners. Sally Pinto, who is from Yonkers Neighborhood Naturally Occurring Retirement Community, and Z. Baird from our library system, from Yonkers Public Library. We thank you for your, participation in this and for helping us spread the word and getting information out to our community. So thank you very much. So without further ado, I would like to introduce our speaker today, Dr. Rajendra Rampersaud, who is both the Chief of Medicine at St. John's Riverside Hospital. He is also the Director of Sleep Medicine at St. John's. He is responsible for our intensive care unit. So he's a man who wears many hats, and he's incredible and invaluable to us. And we all love him and go to him for all of our sleep questions. So I know he's going to educate us very well today. So with that, I'm going to turn it over to Dr. Rampersaud.
Thank you for the very kind introduction, and thank you for everybody for helping work on this. So like Denise said, we're going to talk about sleep, and I know this is a very broad topic, and I have a bunch of slides to show, and we're going to move some of them sort of quickly just to give you a scope of what is it entailed in sleep medicine. So Jason, if we can you help pull up the slides for me here? Alrighty. So for those of you who know me, I am a big fan of art. So I think one of the incredible things about living where we live is that this is actually Van Gogh, Starry Night, and it's only about 20 minutes from where we are. This is at the MoMA. So I was down there, taking pictures. I don't know if I was supposed to or not, but it's pretty incredible to see these things live and in person. And it's pretty amazing that such incredible pieces of art is actually right here in our own city. So again, our topic today is sleep better, live better. And I'll explain why we do certainly live better if our sleep is better. Next. So one of the amazing things, and I actually didn't know this until I did my sleep training, is there's approximately almost 80 different types of sleep disorders. And when you tell this to people, they're always very amazed to say, well, I only thought there was a handful of them. But when you look at diagnostic criteria groups, there's actually 80 distinct sleep disorders. Now, albeit a lot of them are very similar in nature, but there's very small subtleties to each of them. And so almost 80 different ones. And it's estimated that almost 70 million Americans suffer from a sleep disorder. So if you can imagine the scope of that. So if you imagine the number of diabetics in our country, the number of hypertensive that are very common diseases, there's no way that it approximates this number. And this is probably an underestimation. And this is from the National Sleep Foundation. And these numbers are actually prior to our COVID pandemic. So, who knows what the number is now. And one of the basic premises behind a sleep disorder is that it can affect your overall health, safety, and quality of life. And a lot of people, when they think about sleep and, poor sleep conditions, they don't really think that it can actually affect your health, but it certainly can in very deleterious ways. Next. So I always like to give a little direction of where we were and, where we are and where we're going towards. So sleep actually in 1934 was described as a intermediate state between wakefulness and death. So could you imagine at the time that they felt that if they saw someone sleeping deeply, that they were afraid that they may be on the verge of death? It wasn't until 1965 that sleep apnea was found. Could you imagine that? So with all of this time and all of, the 1800s, the early 1900s, sleep apnea was actually found at the same time in France and Germany. And CPAP, which is a therapy for sleep apnea, which we'll talk about a little bit more, was only discovered in the 1980s. So if you can imagine, you know, what were people doing before to treat these very serious health conditions, and it's pretty amazing. So just to give you a sense of, you know, how far we've come in the last several decades in terms of understanding sleep and sleep medicine. Next. So these are the primary disorders, and you know the reason why they're called primary disorders is because these are the most common. And you know, one of the things we'll talk about now is insomnia, and we'll define it. I'll describe it, and this is definitely something that has gotten worse with our pandemic, unfortunately. Jet lag is actually a sleep disorder. So a lot of people, you know, they just say, "Oh, I'm jet lagged," but they don't actually realize that the mechanism behind the jet lag is based on our circadian cycle. So, for example, if I you know, took one of our staff here and I flew them over to Australia when, you know, it's on the opposite side of the world, they would jet lag because their circadian cycle will be out of sync. So jet lag is actually a sleep disorder, shift work disorder. So, you know, there's a very significant population in the United States and industrial countries where there's people who are shift workers. And, you know, those of us who, our colleagues work overnight, our nurses, our ancillary staff, the physicians, you know, everybody that helps continue our care during the evening of the patients, they can develop shift work disorder. Sleepwalking, sleep terrors, you know, sleep talking. These are sort of things that we see mostly in the pediatric population, but these are considered benign primary disorders. Restless limb syndrome. So it should be limb because some people get it in their arms and their legs. Something called periodic limb movement disorder, which we'll talk about. Inadequate sleep hygiene. So this tends to be a lot of us, right? So people will say, yeah, I was, you know, reading in my bed. I was like watching television in my bed. I was doing work in my bed. You know, I sleep in late on the weekends. You know, I tend to do this. So these are considered things that can be inadequate for our sleep hygiene. Narcolepsy, and of course, sleep apnea. So these are considered the primary disorders. The next couple of slides, we're just going to flash up very quickly because these are all the secondary disorders. And those of you who know me know I'm not a very good typist, but imagine I actually went through and typed all this stuff just so to give an impression of, you know, how many different things. So you can see here's one slide with each distinct secondary disorder. Next slide. Here's a whole nother listing of disorders. Next slide. Here's a whole nother bunch of disorders. Next slide. Whole bunch of other disorders. And so that's pretty amazing. So when you think about sleep and, you know, the challenges people face with, well, why is my sleep inadequate, or why can't I sleep properly, or, you know, I get a good night's sleep and why am I still tired? You can imagine that it's very, very hard to sort of weed through all those conditions because if it's not very obvious that you snore and that you have, you know, certain things, the other sleep disorders can be very difficult to tease out. So the first thing we're going to talk about is insomnia. And I think this is one of the more common things. And this is an estimation by the National Sleep Foundation that almost 30% of adults report some form of insomnia. So if you can imagine the sheer volume of that number. So, you know, there's about 360 million people. So theoretically, almost 100 million people will have this condition. Unfortunately, it is more common in the elderly and in women. So the reason why women sort of trump this type of disorder is because the female hormones after menopause, those are actually sleep protective. And then what happens is becomes a hormonal problem, and women can actually develop pretty significant insomnia as they get older. So the four basic categories are the patient can say, I have a difficulty falling asleep, I have difficulty staying asleep, I wake up too early, or they can sleep the entire night for a normal number of hours and they still feel their sleep quality is poor. Next. Treatment. So the basic treatment behind this is actually not medication. So I have a little list of medications, and I'm sure as everybody can look at the list, the one that's sort of on the top of the list is Ambien. And by itself, Ambien is actually a very good medication. Sometimes it gets a little bit of a bad rap, but if you can imagine, in the United States alone, there's probably about 45 million prescriptions written for sleeping aids. I mean, isn't that incredible, the number by itself? And a significant portion of that number is for Ambien. The long-term treatment for insomnia is really some type of behavioral therapy. So, most of the times what we do is, in order to help the patient in the short term with their sleep, they can be prescribed medications, and you can see different medications on here. I don't have melatonin listed there because it tends to be more of a holistic thing, but melatonin actually works quite well. And just as an aside, the way I got interested in sleep is that I was the nighttime attending, so shift work disorder. And I've always been the type to have short sleep, and I tend to thrive in the evening. And after working in the ICU at Einstein for a number of years in the evening, I actually developed insomnia myself, especially in the days that I had off. And so when I started reading about sleep and insomnia and shift work, it became so interesting. I actually went back and did fellowship in it. So the long-term management of this is really to use some type of behavioral therapy. And we actually have some very good allied health professionals who actually work with us here, through the sleep center that, if you ever need any type of assistance, myself, Dr. Malkani, who's the other sleep doctor, Dr. Gunzer is one of our psychologists, and he is fantastic at teaching people normal sleep hygiene, which is just how well we perform our nighttime routine, and also behavioral therapy. And that long-term is really the ultimate goal for treatment of insomnia, because medication tends to be just a very quick fix. In fact, for most of the sleeping aids, there's only two medications that the FDA approved for longer than 6 months. Beyond 6 months, they haven't been studied. So if a patient shows up and they said, well, I've been using a sleeping aid, for the past 2 years, do you know what will happen? We actually don't, because nobody's actually studied it for that long. So these things should be prescribed for just about 4 weeks or so. But unfortunately, we do have people who are on them for many, many years. Next slide. Shift work disorder. So, depending on the type of work and the hours of work, so this is basically a circadian cycle. And what that means is that we all have a internal clock inside of us. And actually, a number of years ago, the Nobel Peace Prize for Science was actually given to a circadian clock study. And they found that our universal clock is called tau, and that is 24.2 hours. How they got that extra 0.2 hours, I'm not sure. But anytime you move your circadian cycle from one time zone to the next, you can have a shift work disorder. So, for example, people who work at nights, people who work mid shifts, and the ones who generally have the hardest time is those who have a rotating shift. So, for example, just say this week I will work Monday, Tuesday, Thursday, from 9 p.m. until 9 a.m. and then the next week I'll work Wednesday, Friday, Saturday. So people who have a rotating shift with different nights and different hours, they most certainly have the hardest time with dealing with shift work, because there's no way for them to sort of equalize what they're doing. If people do have to work night shifts, it's always better to have a set schedule as much as possible. And it's really important to have really good sleeping habits, because, as most people know, those of us who've worked at nights, is that after you get out of your shift and you come home, now there's family responsibilities, and you have, your partner to do things for, you have your children to do things for, you want to get stuff done and pay your bills. So people who tend to shift work, they on average sleep much less than the normal population. And in fact, what happens is these people have a much higher incidence of metabolic problems. And so one of the dangers of the metabolism problems was COVID. So we saw that a lot of people who had hypertension, diabetes, and dyslipidemia, they were very, very prone to getting COVID and also getting very ill with COVID. So this is a really important thing for people who, functionally, unfortunately, may have to work in the evenings or these mid shifts, that they really try as much as possible. Now, I always tell the patients with these things, it's always a work in progress. So you shouldn't be nervous, or you shouldn't be scared that, look, I have to work at night because of whatever the situation is, but take little steps, moving forward to try to make your schedule as normal as possible, as consistent as possible, and to actually carve out proper time for sleep. Next. So again, these are some things that I mentioned. So in general, shift workers tend to sleep sometimes up to 4 hours less than, people who don't work in the evenings. Their quality tends to be very poor in terms of the sleep. Obviously, with these type of things, if you're out and about during the daytime, risk of driving accidents is higher, risk of injury is higher, and the condition does last as long as you tend to work those schedules. Now, the nice thing is is that when people go back to a more normal schedule or a daytime schedule, some of the medical issues that they may or may not have developed can actually reverse itself. So really important for consistency. Next. Again, treatment is to keep your circadian cycle as normal as possible, and what that means is to reduce the number of times that you actually shift, from the days of the week. Try keeping the hours on a regular basis, and if it's possible at all, to have a little break in between. So even a 30-minute nap will actually help. And we actually have studies looking at physicians and nurses that even a 30-minute to 45-minute nap in the middle of a nocturnal shift will actually help. And people will have increased psychovigilance, they'll have increased reaction times. So, if it's possible for your employer to allow for, a 30 to 40-minute resting period, that's actually quite good. And use of light therapy. So this is something the sleep community sort of goes back and forth on. And basically what happens is that the receptors for sleep are actually in our retina, which is the part of the eye. And when the sunlight hits your retina, it actually suppresses melatonin release. And what happens then is that when the melatonin is suppressed, that's the waking hours. And when the sun goes down and the stimulus is taken off of your retina, the melatonin level, which is made by a gland called the pineal gland in your brain, it starts to go up, and that's how sleep increases over the course of the night. So some things that we used to do in the past, now again, if you look at the American Academy of Sleep and some new literature, they're actually saying the light therapy may not be the best thing that people can do, but I can tell you that in certain scenarios, anecdotally, the light therapy definitely works. And, I know those of us who have been here working with the pandemic, every once in a while, you'll see people randomly walking outside trying to get a little sunlight, a little light into their lives. So definitely having a little bit of light has a lot of positive effects on people. Next. So restless limb syndrome, before I had listed as restless leg. So most people commonly will sort of describe movements in the leg, but some people actually have it at their upper extremities. And basically, this is a sensation that they'll feel mostly when they're going to sleep. Some people actually can feel it prior to the sleep period or even hours. The United States and Europe actually have pretty high incidence, 15% on the high side, which is a pretty decent number. Lowest rates are in Asia. And basically, the things that the patient will describe is that prior to the sleep period, what they would want to do in order to get comfortable is to move their limbs, either their arms or their legs. And if they are unable to do that, they actually feel uncomfortable, and that sometimes disrupt their sleep. Active movements actually relieve it. So these are the people in the middle of the night that say, I get a lot of quote unquote Charlie horses. So sometimes it is a little muscular cramp, but if it's happening consistently, it may not be something that's, due to your body electrolytes or to muscle movements. It may be restless limb syndrome. Rest tends to initiate the symptoms. So as they're trying to relax and wind down for the evening, they start to now have these symptoms. And the nighttime and the evening symptoms tend to be worse in the morning. Now, there are some people who unfortunately experience this a lot during the day. People who are anemic, people who have iron deficiency, pregnant women, which is actually quite common in pregnancy. People who are on dialysis. So a lot of the end-stage renal patients and kidney disease patients, they actually have a lot of these symptoms. Now, it could be secondary to their primary medical issue, but sometimes the problem is actually related to restless limb syndrome. And this is a cousin to another condition we're going to talk about shortly. Next slide. Again, so causes: pregnancy, end-stage renal, iron deficiency, people of neuropathy, so people who are diabetic, people who have any reason to have, neuropathic diseases, and some medications. So the antidepressants can do it. A lot of the antiemetics, sedating histamines can do it, and dopamine active agonists can actually do it. Next. So treatment is regular exercise, trying to reduce caffeine and alcohol before bedtime. So a good general rule, because a lot of people say, when is the last time I should have some caffeine or alcohol? So gastric emptying time is about 4 hours for most people. So anything, longer than 4 hours should be good. And if you do something in less than 2 to 4 hours prior to bedtime, those things can actually alter your sleep. Keeping mentally active, really important. Massaging the legs. So I always joke around with people who come in with their spouse to say, that's their job now at night. They have to give them a little massage before they go to bed. Soaking in a hot tub, if you have hot tubs. Iron deficiency, if it's present, magnesium and quinine anecdotally help. So the quinine is something they used to prescribe, but then quinine can actually be toxic. So it can actually give you some bone marrow suppression. But one little trick that some of the patients use is drinking tonic water. So tonic water actually has small amounts of quinine. So drinking about 8 ounces of quinine with a little bit of cranberry or a little bit of juice, 4 hours before bed tends to help. And obviously there's prescription medications. The prescription medications, though, are a double-edged sword. So these medications are very similar to the Parkinsonian drugs. And what happens with these medications is that it can actually bring on symptoms earlier in the evening. And it's called augmentation. So basically, just say the patient started having symptoms at 10 o'clock at night. After a certain amount of time from being on medications from this condition, they could actually start having symptoms early in the evening, like say 9 o'clock, 8 o'clock, 7 o'clock. So in this condition, again, like most sleep disorders, you'd like not to use pharmacologic treatment, but try to use, something holistic, something that's, exercise, hot showers, massaging, to try to treat the condition as long as possible without taking medication. Next slide. So basically what this tends to look like is, the partner in the bed saying that they're restless sleepers, or for example, they're constantly like scratching their feet against your feet or moving their arms constantly. And this is something that can be very disruptive for the partner and for the patient. Now, the amazing thing with the sleep disorders is that they're happening when you're sleeping. So a lot of the times the patients with these conditions, they actually don't know it. But what the partner will see is sometimes little simple repetitive movements of the big toe or the foot, and you may think it's just somebody moving around. And again, this often occurs most commonly in the lower extremities, but it can certainly happen in both arms as well. Next. Again, here are some of the causes, which is very similar to the restless limb syndrome. Some of the antidepressants, antiemetics, people with kidney disease, Parkinson's disease. So some people think that this may or may not be a precursor, not to link the two diseases, but it is very similar in their mechanism and treatment. People who have ADHD, it's common, pregnancy, post-traumatic stress, and MS. So, but again, when you're looking at these lists and you're saying, well, you know what, I think I may move my legs or have a little RLS, please don't think you have one of the more serious conditions, because this is actually quite a common condition. So it's most likely to be something very, very benign, which is more of a sleep disorder than one of these, unless you have one of these things as part of your medical history. Next. I think we can skip this one. Next. So inadequate sleep hygiene, and this is always a challenge, I think, for a lot of people. So this is basically a very fancy way of saying people have bad sleep habits. And, as unbelievable as it sounds, having bad sleep habits can actually ruin a night's sleep and actually can keep you from getting really nice, consolidated, refreshing sleep. So things that are sort of common is, alcohol before bedtime, caffeine before bedtime, nicotine before bedtime, and this includes smoking a cigarette. It includes vaping and any way that you can get nicotine into your body. Worry, excitement, stress, physical activity before bed, or engaging activities while in bed before sleep onset. So really common, people will sort of snuggle up in bed and, watch like The Late Show, or they'll watch a movie, or, work on their laptop, or, look at their device. So those things actually are considered bad sleep hygiene if it disrupts your sleep. Now, one of the things I should have sort of mentioned before is that some people will say, well, look, I do, either one of these things or many of these things prior to bed, and I actually sleep okay. So it's only considered pathologic if your sleep is not the quality you want it to be. Not to say that you should do all these things if you feel your sleep is normal, but sleep becomes a pathologic condition when you feel that you're not getting enough sleep, you can't fall asleep, you can't maintain it, or you feel sleepy when you get up. So that's the one caveat to all of the 80 different sleep disorders. And the last one I have in here is watching the clock. And I'm a bad, example of this one, because I tend to do that. I have 6 hours before I got to get up. I got 5 hours before I have to get up. So a lot of times watching the clock is something that really drives insomnia and inadequate sleep hygiene. And the simple thing, what I did was I have it in a part of the room where I really can't see it, but I could hear it. So that's a little simple intervention to get rid of that last one. Next. So again, like most sleep disorders, when you have inadequate sleep hygiene, it can definitely lead to a mood disorder, such as depression, anxiety, shortened attention spans, poor concentration, daytime sleepiness, A lot of people get frustrated with sleep, so this starts a really bad sort of cycle, because before the sleep period now they start to anticipate not being able to have a good night's sleep, and that tends to drive the insomnia. Caffeine dependence, so if you don't get a good night's sleep the night before, a lot of people, if they don't have that morning coffee or 2 cups of coffee, they can't really get their day started. Or alcohol abuse. And the way this gets started is that some people will notice, well, hey, when I have a drink, I tend to fall asleep a lot faster. The problem with that is that the alcohol now shifts your sleep architecture. And basically what happens is that your sleep latency is shorter, which means you can fall asleep faster, but you actually do not go through all of the normal sleep architecture. So from stage 1, 2, 3 in rapid eye movement, it's actually shifted. So the overall sleep quality, if you try to use alcohol as a sleeping aid, actually gets worse over the course of time. So that's definitely not a good idea. Next. Treatment. I mean, it sounds really, really simple, almost too simple, but being consistent. And, those patients that come in who have, sleeping issues, what I do is I make them do what's called a sleep diary. Because a lot of times people say, well, I'll tell you exactly what it is I'm doing. But then when you try to track it, you actually see there's a lot of subtleties and maybe some big changes in what you do from night to night. So, being consistent in sleeping habits is the key to actually almost all the sleep conditions. Making the bedroom and the bed as comfortable as possible. So, for example, especially for the shift workers, to make sure that the room is really dark. So my bedroom is like this dark teal color. It's like a cave, so I like it to be on the cool side, comfortable bed, comfortable sheets, and, not a lot of distractions in the room. So, there's not a lot of, the alarm clock has a very subtle, red light to it. So keeping the room, as dark and comfortable, and temperature too, because, I'm sure those of you who have been in a warm room and a cold room, it's hard to sort of get a good night's sleep or to take a nap or whatever you want to do. So always having a nice, comfortable room and bedroom that's quiet. Relaxation exercises. So, these can definitely help, having a little bit of meditation before, the sleep period, or having like a little, relaxation sort of technique before you go out. Staying out of the bed until you're ready to sleep. So sometimes what happens is people now, when they get into the bed, there is like this mental trigger that says, okay, now I'm in the bed, it's time to watch news or watch the Late Show, or I'm going to watch a movie before I go to sleep, or, I'm going to get out my laptop and work on stuff for work. So again, if your sleep is subjectively normal and you feel that, in the daytime, in the morning when you get up, you actually feel fine, those are actually caveats to this. But if you feel the sleep is not the way you want it to be, that may be why it's happening. And sometimes sleeping aids are required. So, what's really important to remember is that sleeping aids by themselves are not bad. And, they can have some deleterious effects, but if they're used properly and they're used for the right condition, they certainly can be helpful, but we try to avoid them as much as we can. Next slide. Narcolepsy. So this one is one of the more interesting of the sleep disorders. And actually we have, through the mayor's office, we've been designated to have a National Narcolepsy Day, where we had a really nice ceremony, and it was quite moving, where this young woman who, was growing up with narcolepsy, and it was really incredible because she sort of told us this story, how she always felt that she was different from the other kids, and they thought that she was lazy, and people thought she was taking drugs, and, she was falling asleep in class, and she really thought something was wrong with her. And the whole time it ended up being this sleep condition. And once it was found and treated, she completely turned her entire life around. And it was one of the more moving things that I've heard, from a patient. And it's really incredible how people, with this condition can really feel that their life is out of control. There's two main types, so narcolepsy with something called cataplexy, and narcolepsy without cataplexy. Now, cataplexy is basically a condition when somebody will fall asleep like that. And what's really incredible is that there's basically two types of sleep. So there's non-rapid eye movement sleep, and there's rapid eye movement sleep. And so rapid eye movement sleep is really, really interesting, because what happens in rapid eye movement sleep, it's actually an active brain state, and this is where we do the vast majority of our dreaming. So say that, you're all dreaming that you're in a beach somewhere, swimming in the ocean. if there wasn't a disconnect between your brain and your body, you'd actually be making the motions in the bed. So what happens, when people go into rapid eye movement sleep and they start dreaming, there's a little switch in our brainstem that shuts down muscular movement except for your respiratory system, so you can breathe, and a muscle in your ear. And this is something left over when we were cave persons and sleeping outside, I guess, as a defense mechanism. So it's really amazing how, by grand design, the brain does that. Now, in these individuals, there's a faultiness of that switch. So sometimes it doesn't flip off. And now what happens is that they go from non-REM sleep immediately to REM sleep, and that's why they pass out, and that's what they call cataplexy. The classic thing that a lot of the patients will experience is they'll tell you that the symptoms of the cataplexy tend to happen when they have a lot of intense emotion. So anger, laughter. It typically begins in teens and early 20s, but I have a patient who is 76 years old, and we didn't diagnose her until she was probably in her late 60s. So there are people who will live their entire life with very subtle forms of this. They're estimated about 100,000 narcoleptics in the United States, which is, if you imagine that number, that's quite a decent number. The highest rates are seen in Japan for some reason, and the lowest in Israel. And men and women are pretty equally affected, although in clinical practice, we tend to see much more women coming forward with this condition. Next. So sleep apnea. So sleep apnea is, definitely one of the things that we'll spend a little bit more time talking about. And if anybody has any questions about it. So we thought that there was only actually one type of sleep apnea, but over the course of the years, we realized there's actually many, many different types. So obstructive apnea is basically where there's a lack of airflow from the tip of the nostril down to this level here. And the easy way to think about it is these are the people who snore, and these are the people who snort, and these are the people whose partners say, you know what, I see you jolting in your sleep, I see you jerking in your sleep, I hear you making weird noises in your sleep. So this is all air turbulence. So the easy way to think about it is that if the airway was a tubing, there's somewhere along the tubing where there's a kink, and that's obstructive sleep apnea. And obstructive sleep apnea is by far the vast majority of the different types of sleep apnea syndromes, probably 85% depending on the population that you're studying. There's central sleep apnea. So this tends to be a condition we see mostly in really small babies, so those who are born immature. We can see these with people who take certain medications like opiates, a lot of benzodiazepine medications, a lot of sedatives, people who've had brain injury, people who have stroke. So the way we would observe this is that the patient now would literally not take the next breath. So if we were all observing the patient, in a sleep center or just laying in their bed, the people with obstructive sleep apnea, they would still make the effort to move their thorax and their abdominal wall to take the breath. The people with central apnea will literally stop breathing. So it's a really interesting type of condition, and we can treat all of these, by the way. Mixed apnea, so these are people who have some central component plus an obstructive component. There's something called sleep disordered breathing, which is on the spectrum of sleep apnea. There's something called respiratory effort related arousals. So there is so many things. So it's like the old adage, the more you dig, the more you find. And imagine the incidence of sleep is only increasing. So for example, the number of people in the United States who have sleep apnea who are not yet diagnosed is estimated to be 85%. So imagine 85% of those out there who have sleep apnea don't know they have it and they haven't been diagnosed. And one of the reasons is testing, which we'll talk about a little bit, ease of testing, ways you can get tested. And just imagine, we didn't really know about this condition until 1965, and we didn't actually were using CPAP to treat until the 1980s. So when you think about the history of this condition over time, we're really in its infancy. Next slide. So about 18 million Americans have it, and that number is probably underestimated. But could you imagine? I mean, such a big number of people. So if you tell people, well, I have asthma, people are like, oh, I've heard about that before. I mean, they're estimated there's about 20 to 25 million tops. But I mean, people, won't think about sleep apnea as being so common. Some of the common things that they look for is an increased neck size, so 16 inches, or a body mass index above 25. So unfortunately, body mass index of 25 is actually quite hard to achieve. And I don't want people to take offense, but if you're above 25, which most people are, that's considered overweight. And then if your BMI is 30, that's obesity. And then if you're above 40, that's considered morbid obesity. So, they always say 25 is the number to shoot for, but realistically, if you're not at 25, don't feel bad that, there's something wrong with you. It's just that, when we try to do these things, there has to be something objective that we look for. So it's always looking at the body mass index, which is your height and your weight. Next slide. Symptoms. So these are the snores, like I said before, that sometimes family or the partner or somebody will say, hey, I saw you stop breathing, or you snorted, or you made this weird noise. One of the really ubiquitous symptoms of sleep apnea is excessive daytime sleepiness. So as a group of patients, this probably by far is the most common symptom. So it's people that will say, you know what, I actually feel that I got a decent night's sleep, a decent number of hours of sleep, but I still feel excessively tired. So that is one of the really common symptoms. High blood pressure. So people will say, well, that sounds weird, but when you think about it, if your body is tired, if your body has not gotten adequate rest, the inflammatory state is higher in your body. And so what happens is that this leads to high blood pressure because your body is on high alert. Morning headaches is a really common one, restless sleep, depression, anxiety. So these can be secondary or they can be primary. One of the interesting things is when I trained, my director was actually a psychiatrist, and a lot of sleep doctors tend to be a pulmonary doctor like myself or a neurologist like Dr. Malkani, our other sleep attending here. But a lot of psychologists and psychiatrists do sleep medicine. So if you look at the symptoms of a sleep disorder and the symptoms of a mood disorder, they're almost exactly the same. And so when we treat the sleep patients, it's a really multidisciplinary team that needs to sort of take care of these patients, because it could be something that's a primary mood disorder that people think it's actually a sleep disorder or vice versa. So it's a very common thing to see all of these things. Next slide. Cardiovascular complications. So this is something that, we're definitely building more and more evidence about cardiovascular implications of untreated sleep apnea, and one of the more common ones is atrial fibrillation, and which is an irregular heartbeat. So one of the things we've actually seen and that has been shown is that people who have AFib, even if you have an ablation procedure or you're on the best medications from your cardiologist, you can actually go back into atrial fibrillation if your sleep apnea is not treated. And the risk of having untreated AFib is actually a stroke, and that's something nobody wants. Cardiac ischemia, strokes, arrhythmia, a condition called pulmonary hypertension, where the pressure in your lungs and your great vessels is increased, and metabolic mechanisms. So there's actually increased insulin resistance. So one of the things that's pretty amazing that they've actually shown, and they've shown this in Asia, and most notably in Japan, is that when they treat somebody's sleep apnea with CPAP, their hemoglobin A1C, which looks at their blood sugar over 3 months, actually comes down by 1 gram per deciliter. That's almost by treating it with a medication. So it's actually pretty amazing that a good night's sleep, resting the body, not having increased inflammatory states will actually help these metabolic problems. And we see it. So for example, the people who undergo bariatric weight loss surgery, we have very good bariatric surgeons here at our hospital who do a lot of great work, with our patients. And it's really amazing because, they'll go to our surgeons and they'll have hypertension, diabetes, and high cholesterol and sleep apnea. And after they get operated on, guess what? After they've lost, the weight that they were anticipating to lose, a lot of them are off their medications. They're off their insulin, they're off their pills. So it's really an amazing thing. And this all ties into sleep apnea. Next slide. So treatment. So the ultimate goal for this is weight loss. And like I said before, our bariatric surgeons show this all the time, that getting people down to their ideal body weight definitely will help, not only with the sleep apnea, but their other metabolic problems. One of the other therapies is positive airway pressure, PAP therapy, which is CPAP. And the basic concept behind this is that the device, which is a small machine that's at your bedside connected to you by a small mask, basically creates an air stent. So all that it's doing is putting a positive pressure through one part of your airway, down through the trachea, and all these structures in between that will actually stent the airway. And it actually is, almost 100% effective depending on the pressure that we use. Oral appliances. So the dentist figured out if they make a mouth guard for your mouth and it keeps your jaw in a neutral forward position, it actually can treat sleep apnea. And so we actually have, dentists who actually can help this, and it's quite amazing, especially for younger people, people who have a normal body weight. This can actually treat your sleep apnea. And there's also surgical intervention. So taking out the uvula, taking out the palate. I have tracheostomy on there because, prior to utilizing CPAP in the 1980s, if you had really severe sleep apnea, they used to send the patients up to Beth Israel Deaconess and to Harvard to put tracheostomies in them. So we actually have patients in our practice, from our senior partners who have been practicing for about 30 plus years. They didn't have other ways to treat these patients. So we actually have patients in our practice who have specifically had tracheostomy because of severe sleep apnea in the past. They can do all kinds of things. They can actually move your mandible forward. They can do suspension techniques. The thyroid sometimes needs to be operated on. Nasal deviation sometimes can cause sleep apnea. So there's a whole gamut of surgical procedures that can be done. These are most effective and useful in the pediatric population. So most adults who will have sleep apnea will be treated with weight loss and CPAP. Next slide. So finally, we get to some corona virus stuff. So, they sort of all over the place. We're calling this coronasomnia, which included all of these things and related issues. So the two main contributors to this is stress levels, which we know disrupts people's sleep, and changes in sleep behavior. The other thing too is that people being at home most of the time will create issues, positive and negative. So the worries that people will have is about the disease itself, obviously, so contracting the coronavirus and becoming ill from it. Other health-related issues which may not be addressed, which is a big problem, and it's something that we're really trying to do through our hospital to sort of bring people back to healthcare, because it is safe to come back to your doctor's office, to the hospital, to get testing, to follow up. So just say you needed that colonoscopy during that year and you didn't get it because you didn't want to come to the hospital, or say you had an abnormal mammogram, abnormal scan, abnormal blood test. So there are a lot of patients, unfortunately, who have been in the community that were nervous to come back to some type of provider in fears of catching coronavirus, that their medical problem may have actually gotten worse because of time. Obviously, financial issues, people losing their jobs, not being able to work, psychological and interpersonal stressors, school closures. For those of us, the parents who work, we know when the kids have a day off, it's like mass panic, right? Who's going to watch them? Who's going to pick them up? Things like that. And social isolation and quarantine. So these things definitely drive insomnia and the sleep disorders. Next slide. Some people, ironically, actually did better with the pandemic. So these are the people who now used to work, crazy hours outside of the home, and now they're actually home. So they actually had more time for sleep. They had more time to be with their nuclear family. So, I'm spending time with my spouse, I'm spending time with my children, I'm spending time with my parents. So there were some people, who fortunately may have had a positive effect from, having more home time. Next slide. So some of the common things, again, insomnia is definitely part of the more common ones that we'll see. Circadian rhythm disorders. So advanced sleep phase disorder basically means that I'm going to bed sooner. So if you didn't have anything to do, maybe I'll go to bed at 8 o'clock at night. And there's people who now were going to bed early and earlier, and they're like, what, I'm getting up at 2 o'clock in the morning. I don't know what to do with myself. Or there's people with delayed sleep phase. So these are the partiers, right? So, well, I don't have to get up to go to work, and I do everything by Zoom, so I can, stay up till 2 o'clock in the morning. So now what happens, they got to get up and do something in the morning, and it's like, wow, I'm tired the whole day. So that's called a delayed sleep phase disorder. Sleep apnea. So I have COVID-19 in quotes, because a lot of people were saying, they gained 19 to 20 pounds with the COVID. So, with the weight gain, sleep apnea definitely becomes on the table now as having a medical issue from the weight gain. The sleep hygiene, again, getting up, going to bed when you want, taking naps, when you don't really need to take them. And again, the depression, anxiety, panic attacks, post-traumatic stress disorder, nightmares. So these are all things that, unfortunately, were part of the pandemic for not just the patients, but the caregivers, healthcare workers, and a lot of people in various industries just going through this, and these definitely affect sleep. Next slide. So why is sleep important? So remember, at the end of the day, they thought sleep was a function where you almost died. That's not true. So sleep is a critical biologic function. And so if the organism does not sleep and recuperate and rest, bad things are going to happen. Sleep strengthens our immune system, so getting a really good night's sleep and having adequate sleep. And people always ask, well, what's that number? So we actually don't know, but what the National Sleep Foundation says is that you should try to sleep about 7 hours in a 24-hour period. So I think for most people, that's a fair number to shoot toward. So, if you're like a 12-hour sleeper, so there's actually some evidence-based data that sleeping beyond 9 hours has some negative impacts on your health. So 7 to 9 is the sweet spot in general. Lack of sleep can make some vaccines less effective, which is interesting because, if the organism, again, is tired, your inflammatory state is higher, your immune system is not up to the task, you're not going to use the information that the vaccine is giving you to make as much antibodies. Sleep certainly heightens our brain function and complex thinking. So I always tell, the little kids who come in and their parents are like, well, they don't want to go to sleep. So I tell them, I says, the best sleep in your life is when you're little, because most of your sleep is rapid eye movement, and that's when you consolidate memories, cognition increases. So, definitely getting a good night's sleep gives you more brain power, more memory. And it also is shown that as people get older, especially those with dementia, it can actually help to offset some of the symptoms of the dementia if you have a really good sleep cycle for these people. Lack of sleep can worsen depression, anxiety, or post-traumatic stress disorder. So this is something we can see all the time. Next. So ways to improve the sleep. Again, like we said before, having a set sleep schedule. So when am I going to wake up? When am I going to go to sleep? And try to stick with that as much as possible. Wind up time. So set an alarm clock, not just, when I get up kind of thing because I'm home, and have something fixed. Wind down time, either relaxing before you go to bed, meditation, some light reading. Having a routine, it could be simple as getting a shower before you go to bed and eating meals at the same time every day. That's very important. So not, when I get up, I'll have something to eat, or, later in the day when I have nothing to do, I'll eat something. So to really have set meal time. I mean, one of the things too that I try to do myself, which, they've shown at a lot of commencement speeches, is, this person in the military saying that, when you get up in the morning to make your bed, because at least, you've accomplished something. So it's the same type of premise, right? You're going to get up, give yourself a task, accomplish that task, and you move on with your day, not, when things happen, they happen. Blocking off times for exercise and work. I mean, this is something that's always a challenge for all of us, but, having a little bit of exercise is always good. Avoiding excess alcohol, caffeine, and food. I mean, one of the really sad things that, that we read about when we look at all the things is the amount of substance abuse that's been happening now with the pandemic, because people are home, so there's more alcohol consumption, there's more violence in the home, there's more depression in the home. I mean, it's really sad that these things can be very, very dangerous. And avoid performing work in bed and reserve your bed for sleep mostly. Next slide. See the light. So going outside and getting a little bit of light therapy. I mean, again, if you read a lot of sleep literature, that may say this is not a big bang for the buck, but I think it's something that's free and it feels good when you're outside in the warm weather. So I think it's really crucial to come out into the light a little bit and not get stuck in the home all day. Natural light is actually better than fake light, and that's really important to know. Simple things like opening the windows and blinds to let natural light into your home. Minimizing screen time. So one of the things that we do know is that when you look at a device, that fake blue light that gets produced by electronic devices actually interferes with your circadian cycle. So what happens is it actually suppresses melatonin release on the retina. So remember we talked about before, when the sun hits the retina, it suppresses melatonin. Blue light can actually do that. So, a lot of people with screen time, they just don't feel tired until early in the morning because you're suppressing your melatonin. Napping. So napping, the United States, they put out data that naps are no good. The rest of the world says naps are actually good for you. So I'm on the page that naps are good for you if they don't disrupt your nocturnal sleep. And the optimal time for napping is up to 45-minute nap, usually. Active. So exercising, especially 4 to 6 hours before bed, can be very, very helpful. And the last thing is practice kindness and foster connection, as this can positively impact your mood and sleep. So, if you're nice to each other, nice to everybody else, and nice to yourself, you don't go to bed angry and upset and things like that, which is very common. So that definitely is a good sleep tool. Next. So one of the things that's really important is to know that we are here to help. And, this is our Kovitz Center number. And again, if you want to find out about the COVID virus, if you want information on testing, you want recovery, that's our number there. So it's 914-964-4480. Denise, I'm sure those guys will give you some more information at the end if there's other things. And these are the hours. Remember, we have our EM docs are always here to help, so they can do virtual visits if you're nervous about coming in. Full evaluation by our primary care doctors. So this is a really, really important thing. So I'd like to urge everybody out there to not be afraid to come back to your healthcare providers. So we certainly have, our hospital docs who are in the Boyce Thompson. Our primary care doctors in the community are always a fantastic resource. And I think because there's so many different things that can happen related to the coronavirus in general, that it's always a good thing to follow up with your primary care doctors as a platform. And once they give you an assessment and see what your needs are, then we can lateralize care to whoever you need to see. So for example, if you would like to be seen for a sleep condition, if you would like to have your pulmonary status checked because you had COVID or you had COVID and you don't know if something happened with your lungs, smoking cessation referrals, because a lot of people started smoking and vaping during the pandemic, radiographic imaging. So just say you had COVID and you worried about if you need another scan, behavioral health, endocrine issues, with the weight gain, the diabetes. We can help with nutritional evaluations, cardiopulmonary rehab, or just physical therapy and having mobility evaluation. So, the scope of things that have affected people with the COVID pandemic has been very, very incredible. But again, we are here to help and help in any capacity that we can. Next slide. Questions, and last slide. Again, a picture I took at the museum, the Sleeping Gypsy. So these are all in our MoMA. So everybody go to a museum at some point. We have incredible museums here in New York.
Dr. Rampersaud, I want to thank you for you never disappoint us in the presentations that you do. That was really wonderful. I do have a couple of questions for you. One that someone had written in to us was interested in how they could treat sleep apnea naturally. I know you covered weight loss, and I know you were covering there's the surgical things and then the CPAP. But are there other ways that people can do things to help treat the sleep apnea?
So that's a great question. And I think for most of the things, when you think about obstructive sleep apnea, it's really an anatomical problem. So sometimes, when we try to treat a medical condition that actually has a real anatomy issue, it just doesn't work. One of the simple things is most people will have most sleep apnea on their back. So that's called the supine position. And the reason that happens is that if you imagine yourself laying in the bed, the mandible, which is the bottom part of the jaw, tends to move backwards. And so when that happens, you actually obstruct right at the back here. So most adults obstruct right here at this part of the neck. And the reason why is if you ever gone to the butcher shop and see what a cow tongue looks like, so the bigger part of the muscle is not this little flat part, but it's like this big fist-like structure that's here in the bottom part of the airway. And so people, by changing body positions, can actually help treat sleep apnea. So sleeping in the right lateral, left lateral, or if you can sleep on your belly. I remember when I was in training, they used to make us sew like little pockets onto like somebody's shirt, and they put a tennis ball inside. So when they roll on their back, they get uncomfortable and roll back the other way. So positional therapy is something that you can try, but for a lot of people, the holistic thing is really weight loss. So for myself, and I tell this to my patients, a lot of doctors may not tell personal or private or medical things, but I actually had sleep apnea, and I used the CPAP device for about 3.5 years. And fortunately, and I'm sure those of you who see Denise as well see how fantastic she looks. And so one of the things is that as a community hospital, we have lost how much? 600 pounds?
About 600.
Yeah, so I actually lost almost 100 pounds. So my sleep apnea is actually gone. So I don't have to use the CPAP right now. But if I misbehave.
But that's another question I have. So if you do lose weight, how do you know whether or not you can safely stop using?
Sure. So, I mean, one of the little clinical ways you can do it is about the way you feel. So for me, and I knew I had it. It's just I was being a little bit stubborn, like, a lot of patients are, and especially male patients. So I was waking up with headaches in the morning and feeling groggy. And, you start off a bad cycle because now you don't want to do a little bit of exercise. You don't want to do this. And so for me, it was that I wasn't snoring anymore. So, but sometimes if you don't have somebody to tell you you're not snoring, and sometimes, nobody knows if you are. So what we do is we can test you for it. So either we can do testing back in the laboratory, Or again, and again, one of the things I think that most of us here who will give lectures is to really urge the community that it is safe to come back to healthcare and to get tested and to address your medical issues. But if the people don't want to stay overnight for the sleep testing, there is a way, there is home testing. And the home tests are great because they're the type of device that will never tell a patient that you have sleep apnea if you actually don't. So there are no false positives. It sometimes can be a false negative, meaning that you actually have sleep apnea, we can't pick it up, but then we would bring you back into the lab and do a complete test on you. So testing is really the way to sort of do it. Unfortunately, there's no, because over COVID, the staffing at the hospital and everybody here were very kind that every day I would come to my office, I get little gifts. It would be like zinc and magnesium and cumin and turmeric and all kinds of different things. So, I mean, unfortunately, I don't think there's anything in terms of herbal stuff, medications that are holistic. Relaxation techniques sometimes help. I mean, one of the interesting things is that I don't know if people know what a didgeridoo is. That's that really long wooden instrument in Australia. So people who play wood instruments, their sleep apnea gets better because they actually strengthen the muscles in their airway. So if you can make the muscles in your airway stronger and it stents the airway when you're sleeping at night, I mean, you'll have less apnea. But those type of things. But unfortunately, most of the treatment for sleep apnea are involved with a good medical evaluation and treatment. Now, the nice thing is that for most people, if weight tends to be the main issue for obstructive sleep apnea, if you have central sleep apnea and the other types, those are medical conditions that there's really no holistic treatment for, but those are more serious medical conditions in general that need to be treated, with traditional care.
Well, doctor, you covered the testing because I wanted to get to that testing part also. We do have a beautiful lab in the hospital. It is private, it is away from other floors, and it is very clean. And I just wanted to sort of reassure everyone that if they in fact needed to come in, that it is safe to come in. But yes, you also mentioned the opportunity and the possibility of doing the home testing, and I think that's very important. I did have someone who asked about other options besides CPAP, and I know you brought up something about a dental appliance.
Sure.
But are those really the only treatments, non-surgical treatments available?
No, there's actually different things. And again, when you think about the usage of CPAP, it started in the 1980s. So, we're really in our infancy of understanding the complete disease process and how to treat it and what's the best way to treat it. One more thing about the testing is that, the hospital has actually went an additional step to ensure safety, is that the things that are connected to the patient are actually disposable. So they're not reused, they're not wiped down, even though wiping things down in alcohol is actually safe. We actually dispose of things to make everything nice and clean. So it's not like you're going to use something they placed on me or somebody else. So, and the home testing as well. So the home testing are devices that are individual. A lot of them are disposable, once they download the data. So again, you're not going to get something in the mail or pick up something from the hospital that you'll actually catch COVID from. In terms of the treatment, so there are devices at home like CPAP, they're called AutoPAP. So that's what I used to use. And I think a lot of the patients now, because I had a positive benefit from it, and basically what happens is that the traditional CPAP is a device that gives you one pressure, and we titrate that depending on what you need. Now, just say I lose weight, the pressure I need may be less. Just say I gain weight, the pressure is more, and that's sometimes the negative experience patients will have. What the auto device does is it actually titrates the patient on its own. It's a smart device. The dental device actually works quite well, but if the patient is obese or morbidly obese, they tend to have less favorable results because it can't offset that weight that the patient has. So the dental devices can work really well and they can work long term. There's also a device called an Inspire device, which a lot of patients ask about. So this is an implantable device that it comes in like a pacemaker. And basically what they do is they put little electrodes into the base of that big tongue muscle, and the tongue moves forward, during the sleep cycle, and that actually is helpful in certain patient populations. But those are the main paradigms and the surgical options. So when you think about it, weight loss by far is the most common best treatment. Positional therapy is something that may be useful if your apnea is worse on your back. The CPAP is generally first line gold standard. Then comes the mandibular devices, which is the mouth guard made by a dentist. And then a lot of times surgical procedures can be helpful.
So, doctor, tell me, how do people access sleep testing? Do they need a referral? How does that work?
Sure. So it's quite simple. So you could either go to your primary doc, and what they do is they'll fill a form out, and it's a pretty simple form. They'll just check off the test that you need, and they'll also put some baseline information. For example, if you're hypertensive, if you're diabetic, if you had certain types of allergies. They sign the form, they fax it over to the hospital, and then our team takes over. A lot of the times there's an automatic thing for the physicians or the community providers that there's a little box on there that if you check, to see the sleep specialist prior to testing or after the testing. So what I generally recommend is to, if possible, to see me after the testing, because this way I can sort of take over, and Dr. Malkani can also take over and sort of organize all the test results, and then, see the patient rather than seeing them once, saying, hey, do you snore, things like that, send you for a test and have to come back. So the community doctors are more than welcome to order the test, and it's quite simple. And if anybody here is a provider in the community, just get a hold of us and we'll send you these sheets that we can, explain how to use them. There's some offices that we've been customizing the order forms for them. So that's something we can do too to make it make life simpler on everybody, because I know everybody loves to do paperwork in the office. So, so there's ways we can simplify the order. And that's basically the way that the test will get ordered.
Very good. Well, Doctor, I want to thank you very, very much for your time, for your expertise, for everything that you offer to the community and to the St. John's community. You are a very valued member, and we appreciate it. To the rest of our producers, my team, our IT department, and our community partners, thank you again for your participation and for helping us get the word out and helping our community get healthy. We'll see you next time. And we're going to put up on the screen, there are some numbers that I think that we can share. One is, if you need a doctor, then you can certainly call our physician referral number, 964-4DOC, which is 964-4362. Our post-COVID-19 program number is 786-0013. That's if you're feeling that you may be experiencing some issues having had COVID in the past year. And we can work with your physicians to get you the kind of referrals that you need. Sleep Services is there, and our regular information email. If you have questions, feel free to use that, info@riversidehealth.org. And thank you all again. It's been lovely sharing this time with you.